Hello, everybody, and very welcome to another episode of our discussions on the brain, this extraordinary, miraculous organ in our head, which helps us be what we are and what we can be and what we want to be. So it's always fascinating to discuss around the mechanisms and understand about the functionality and the way that the brain works, and also realize what happens when the things are not ending up as they should be. The pathology, the neuropathology. We discussed about some of these fascinating things for the past several weeks, and we're on our journey to discuss even more about this kind of interesting ideas. My name is Mohammad Nami. I'm the Director of Brain, Cognition, and Behavioral Lab at Shiraz University of Medical Sciences. And the program comes to you from the Togetherness Media, Los Angeles. In the 8th episode of our discussion today, we have decided to kind of discuss around another neuropathological, unfortunately tragic conditions, which might be life-threatening in some instances and many instances, in fact. And that's brain tumors. The brain tumor is something which is in many conditions well manageable, provided the diagnosis is timely made and we provide the patients with appropriate treatments, either the surgical management or the medical treatments, ranging from chemotherapy, radiotherapy, or other more advanced therapeutic options that we have today. We have chosen this topic because of its significance and also its relative prevalence in the society. People at different age ranges may come out with this diagnosis. We might know about the presenting symptoms of brain tumor. Also, we got to be having a better understanding about different types of brain tumors and when the condition arises, what we need to do and how we can expect that the patient would survive and live a good quality of life. And that's actually the aim of the treatment efforts. We perform all the diagnostic and therapeutic measures to help the subjects not only survive for an extended period, but also help them have a better activity of daily life and have a better quality of life in general. So, strictly speaking, the whole range of brain tumors are categorized into two separate superfamilies of tumors or malignancies in the central nervous system. The first is the primary brain tumor category, and the second is metastatic class of tumors. Let's talk first about the metastatic brain tumors because they are more prevalent. The source of the malignant cells, the source of the cancer cells are somewhere outside the brain and central nervous system, but we have this invasion. We have this infiltration of those malignant cells into the central nervous system, which causes metastatic brain tumors. The condition is vast and it's diverse in terms of the clinical presentation. In many instances, when we have this initial presentation of the central nervous system, tumor-related symptoms, we got to go for a whole body scan to make sure where the source of this malignant cells are and where they're coming from, actually. And for the primary brain tumors, we have the tumors which are arising from the nerve cells, the neurons, which are not quite prevalent sort of brain tumors. But the more prevalent sort of primary brain tumors are gliomas. So we have the glioma cells as the supporting cells. They are not neurons, we know. But they are the supporting cells within the nervous system, and they are just helping the neural cells to survive, have the better microenvironment around them, and to communicate in a better way. But the genetic formation of these glial cells is susceptible to any kind of carcinogens, maybe radiation or genetic factors or any kind of epigenetic insults that we're confronting. So in those cases, we have the mutation of the gene within those glial cells, and the glial cells will get dysregulated with regards to their proliferative capacity. They go for cell division in an unregulated fashion. So that's why we have the tumor. That's why we have this dysregulated immune system, dysregulated genetic control, and also the cells will get misshaped and they have this unregulated or dysregulated, growth of the cells and proliferation of the cells. The brain inside our skull is limited within like a limited space. And when we have a space occupying lesion, which is not supposed to be there, then it causes the pressure effect. So the vital areas in the brain, so the eloquent cortical and subcortical areas in the brain would get negatively impacted, or they will be damaged, or they will be, receiving an insult under the pressure from that space occupying lesion. So that's why we would have a whole range of different functional deficits, including motor deficits or paralysis. Patients may come up with visual loss or hearing impairment. They might be having dysregulated electrical balance in the brain. They might be having epileptic seizures. They come to the clinic with headache, with seizure, with loss of consciousness. So these are the presenting symptoms that people may come, present with, and then by that we normally, when the case, indicates, we go for the brain imaging. And in some instances, unfortunately, it turns out that the patient has space occupying lesion, like a tumor inside the head within the brain parenchyma. And by that, we need to do a proper planning for surgical removal of that tumor, number one. Also to go for radiation therapy, just to kill the malignant and cancerous cells within or around the area that the primary lesion or the primary space occupying lesion or tumor was seating. So by that, we got to be doing surgery as one of the first and most important steps in the treatment protocol. And then by that, after surgery, we do the biopsy, of course. We diagnose the type of the tumor. Then we do the surgery, and then we go for a radiation therapy with or without chemotherapy. And in many instances, after the radiation therapy, there might be an indication to prescribe chemotherapy, maybe oral chemotherapy or intravenous chemotherapeutic agents will be administered. So let's a little bit discuss about different types of brain tumors. We have this whole, super family of different types of tumors. They might be primary brain tumors, or they might be metastatic brain tumors. In terms of the metastatic brain tumors, the source of the cancerous cells, the source of the malignant cells are outside the central nervous system, but they do this infiltration. They make this invasion to the central nervous system, to the spinal cord of the brain. We have the metastatic brain tumors, which is quite prevalent. And also we have the primary brain tumors. Specifically, we discussed about the gliomas. The gliomas are different in terms of their grades and in terms of their stage. The stage means how invasive and how extensive the tumor is. And if we have many areas of the brain which are negatively impacted, or the tumor is well focused, it has been some kind of, in a limited space. So we know where exactly we're going to take the tumor out. And these brain tumors, mainly gliomas, might be low-grade gliomas, or they might be high-grade gliomas. We have four different levels of the tumor grades. The grade 1 and grade 2 are low-grade gliomas. This means that the type of the glioma is not so invasive, and they are not going to grow in a very fast pace. So by that, we can expect that the patients would stand a better chance to live for an extended survival period. But when we have the grade 3, which is an aplastic, this means that we're facing the malformation and also like an invasive nature of the tumoral cells, mainly astrocytomas, that they are types of glial cells that they are termed as malignant. So it's called astrocytoma. So when we have an aplastic astrocytoma, this means that these cells have a very malignant, quite a notable malignancy potential, so they can turn into a very advanced life-threatening condition. And the last and most advanced type of tumor, which is the highest grade, that's called Glioblastoma Multiforme. And that's critical because still we do not know how exactly the state of knowledge in neuroscience can help those patients to get rid of that tumor. Although we do the surgery, we do the radiation therapy, also the patients are given chemotherapies like temozolomide, for example, if you've heard about that. But the situation is still very life-threatening. The situation is of poor prognosis, and the patients can hardly survive for more than a year. Now, this is tragic. We all know about that. But still, we're on the prime of the journey to understand about new advances and new therapeutic options, targeted therapies, immunotherapies, and something that we can help the patients to survive. And also, most importantly, when we are in the midst of the journey of the treatment, we got to provide a properly designed and indicated rehabilitation therapies, okay? So some like occupation therapy or physical therapy, sensory rehabilitation therapy, and many different kinds of, neurotechnological advances could be employed to help those cases to just, like to ease up the process of combating this brain tumor and malignancy. It's a multidisciplinary approach. There are lots of different disciplines in medicine and surgery that are coming together. It's like a consortium of the doctors and specialized, teams that they are teaming up together to diagnose, to treat, and to make a better surveillance for the course of, follow-up for those cases. So one of the other things which has been less attended to is the emotion dysregulation, also the cognitive impairments that those cases may come up with. We see many patients with brain tumor that they are sort of, up to our knowledge so far, they have sort of been properly managed with the surgical and the medical approaches, but they still suffer from different cognitive and behavioral predicaments. So we need to understand about the extent of cognitive deficits in those cases, to help them have a cognitive rehabilitation therapy when indicated, to just make this concurrently prescribed and followed with the medical therapies, chemotherapy is indicated. If there is a need for redo surgery, we go for it. So we got to do all the efforts as much as possible to help the patients live a better quality of life. That is the most important objective and goal that we're pursuing in neuroscience as we stand now. It's like a teamwork. Surgeons play a critical role in that. Either the spinal tumors or brain tumors, first they are in the hand of surgeons to get precisely and also do the maximal safe resection of the tumor. This is very important. And then before that, we got to know if there is a need for surgery even at the prime of the treatment journey, or no, we can just go for a watchful waiting process and go for the treatment. And after that, so the pathologists, the neuropathologists, the neuroimaging specialists like radiologists, neuroradiologists, we have the neuroscientists that they do the functional neurosurgery for functional neuroimaging for planning prior to the surgery. So what we do as pre-surgical planning, when it's done by the advanced neuroimaging technologies, which are basically tended to in the field of applied and clinical neuroscience. And the excision of the tumor is very important. Sometimes we need to have a very minuscule, very, very advanced and very fine methods to excise the brain tumor, not to harm the sensitive areas of the cortex. And sometimes we go for nano-neurosurgery. And in the Society for Brain Mapping and Therapeutics, our colleagues and professors, there are an expert panel of doctors that they have written and composed the first edition of the nano-neurosurgery textbook, and they are just in preparation for the second one. They're talking a lot in that book, talking a lot about how to maximize the extent of safe resection using the advanced technologies. And after that, the chemotherapeutic agents need to be very precisely and carefully selected and prescribed. And by that, we got to know about the chance of helping those patients with neurorehabilitation, with social and also mental health counseling and stuff like that, to help them stay as safe and as functional as possible, And by time, we might need to do serial imaging to do the follow-up. So it's a lot to discuss about this brain tumor, which is collectively referred to, brain tumor science collectively referred to as neuro-oncology. So today, we just opened the window to understanding some key terms and the hits and misses that we have in the field of neuro-oncology and how we can go hand in hand to develop new insights and new technologies and new treatment solutions to help those patients with brain tumors, specifically high-grade gliomas. Thank you for listening, and I hope nobody will have this disease, but when the case is that, we have no way but to just come together, become like a multidisciplinary team to help them as much as possible. Really appreciate your time and your attention. Thank you for listening to me and appreciate your turn in. Thank you. See you later.
Togetherness Media. Togethernessmedia.com